Pretty big crowd after lunch here. I'm CJ Peak. I'm from a psychologist from the University of Minnesota, family medicine. I'm in the faculty there, and was involved in the creation of this product along with the Farley Health Policy Center.
Hi, I'm Sandy Blunt. I am a professor at Antioch University and still a little bit of professing at UMass Medical School, and I also was involved in this project. We were consultants to the project. This is how we'd like to have the presentation flow today. We're going to start out talking about why this was done and why it makes a difference, and a little bit about competencies as an idea. Then we're going to go through the method that was involved in this set of competency discussions, and it was a method that I get to say I thought was incredibly creative, since I didn't create it. You'll never guess who did. And then we'll talk about how it might apply. Hope to have a time to interact with you a little bit about how it might apply in the world that you live in. These are our learning objectives, and we hope that you will meet all of them. I tend not to spend a lot of time on reading them. So, why this, why now? This process was begun because Colorado has more impetus for general implementation of integration than I think anybody out there, or certainly they have a lot, let's say that. And they have people gearing up all around, and they have had the concern that they were going to have a lot of very different kinds of projects, all saying that they were doing it just like it was supposed to be done, and they don't have a central authority. There's no person or group who can come in and say, you guys are right and you guys are wrong. It was whatever, and so the image that came to my mind was, you guys are probably too old to remember all the old movies, black and white movies, of the Oklahoma land rush, and all of the wagons just heading into this territory now that genocide had worked its magic. And so this was the idea of, what if we had a community instead of a land rush here? And so we would assemble, bring in, talk with, create a process so that there would be an agreement, a consensus on what would be the competencies that we'd be shooting for. And that would allow then you to have a foundation for training, for funding from foundations, for instance, for selecting people as candidates, or having candidates select programs because they could evaluate them, for evaluation, funding by payers, policy decisions. In other words, this is sort of the place to start for a lot of things, and if you're going to have it feel like a community, but a community that people participated in. So it allows people to begin to work together. It gets away from the possible toxic kinds of competitions that might show up. And the other thing that happened, and it happened demonstrably in this process, is because this whole thing of integration is an evolving process. Nobody's got it just right. It's not old enough for people to get it just right. the process of the exchange around competencies lifted all boats in terms of expertise. People went into the guts, the gravel of how we do this, and looked at the overarching ideas of how we do this in a way that everybody got a little smarter doing it. Think that's fair?
Yeah, I think so.
Okay, did I fail to? Oh, once I get to talking, I stop doing the slides. So here are the people who, walking and chewing gum is not really one of the choices here. So these are the folks who were the foundation's folks who supported it generously. And should I go on with what's tricky about competencies, or you want to add a little bit here?
Well, only that the state wanted to know what are our licensed behavioral health providers supposed to be able to do, and we need a common vision for it. There were a lot of people really interested in it. Not only did they have this big SIM grant where they're promising CMS, we're going to do this consistently, but you had the foundations in the state, it's like 5 of them, interested in supporting this, funding things, keeping it going. And the foundations were also concerned that when they read the literature, there's like competencies all over the place. And so what is the version in Colorado? And how can you guys, you providers, reduce the cacophony that's out there? Because as foundations, we're a little afraid of the cacophony. Can we come up with a common set that we agree on, where people are in interaction, just like Sandy said, down in the weeds to understand each other and then say, oh, okay, yeah. And that's kind of where it is, but it's a tricky area.
So I had been involved in this competency thing from creating training programs for a long time, and I had been, my kind of language was that this whole thing that we're doing in integrated care is modular skills rather than disciplinary skills, and that it crosses disciplines, and that no discipline does a fully adequate job of preparing its average person to do this work. So we looked at the concept of competency, which is a kind of elusive thing. Is it something that you can see somebody doing? How would you know it was competent? Wouldn't you have to be competent to know that was competent? Or is it kind of general? It's kind of could you see somebody, watch somebody for a day and begin to know? So there's the issue of multiple competencies already out there, different altitudes, general versus very specific. When you read these competencies at the larger overarching title level, they all seem pretty obvious. You say, really? You went to Denver to do that? As you unpack them, lo and behold, important stuff comes out. Then we struggled with the issues of lumping or splitting. So if you lump things together, you find things that really are part of a whole area of work, and why would we make them into little pieces? And on the other hand, then you can't have a videotape of somebody doing it, right? On the other, if splitting, you can get it down to all these little things of, reflecting someone's speech or various things. But how do you see the judgment of knowing when to do what? It's acontextual, and it's the context that makes this expertise work. So it's a struggle. And then the other thing that I find very compelling as we look at this is how much more competent people, clinicians, look in certain organizations than in others. That has to do, in my judgment, with the competency of the organization. There are ways of having people interact, because that's how we do it here in Smith & Jones Healthcare, that makes them work well together. They don't have to create the success of the interaction. They just have to be there and do their part. And those differences often are not not realized as part of many of the competency documents we looked at. The competency documents, the APA competency documents, tend to be very individualized. I think when I look at the APA documents, I think of the psychologist who does this as the infant Hercules astride the flood. You know, they can do anything because they're the psychologist who can do this. And the whole area of organizational competency is kind of lost. And then there are geographical dialects of people who do it this way in this state and that way in that state, and we don't really know whether they're the same or not because we talk about it differently, that sort of thing. So it means that, and these little things make a difference, right? These little routines help us be together or help us not be together.
Have you ever had a meeting where you had a struggle between the lumpers and the splitters? People wanted a few big categories and those that wanted to break it down. These are the kinds of things, and this product tries to do justice to both lumpers and splitters, different altitudes, all of that, so that you don't leave anybody out.
And there were some givens in this. One was we're just working on the behavioral health clinician, the licensed behavioral health clinician. Might apply in a lot of other areas, but that's all we're working on here, so that we don't end up splitting off. We are looking at retraining the workforce rather than trying to argue with any graduate school about their curricula. We are creating a set of competencies that we will shoot for, but it is not a prerequisite in order to do the work. We didn't feel that we had the authority or the wisdom to do that. And so we're not starting over. We're assuming the competencies that people come out of graduate school with, and we're building on that. And consensus to us meant most folks agree, and the ones who don't can stand it. They would allow us to go on. And that conversation came up several times in the room. Can you live with this? Those of you who don't like it, can you live with it? And if somebody said, no, I can't live with it, there was more process. Yeah. We worked on it some more. One of the things that happens, though, in a meeting is, as the day gets later, people can live with more and more. You'd be amazed. So, go ahead.
Okay, great. All right, so you can see that, like anyone, we had a customer, and they had some givens. And somebody might say, well, this is, you're doing licensed, you're only doing it for the behavioral health folks. What about everybody else? What about the doctors? What about the pharmacists? What about everybody? But again, it's a team sport. I thought this was a team sport. But again, the need in Colorado, the pragmatic need was to say, what do licensed behavioral health people have to be able to do in common that we all agree on? That was their thing. So it couldn't get too philosophical. So it's limited, even though it's a team sport. However, one thing I want to say is that the product was designed so that it could be adapted and extended, and that other disciplines could pick it up and make adjustments to it. So it was like a platform, and there could be a family of variations on it. And one of the things we're going to come back to you in the end is there a variation on this that you can use where you live, in your state or your area, and we'll talk a little about how you could do that and get your ideas. How many of you here think you might need some consensus competencies at some point where you live? Yeah, fair number. And the question is whether you want to start from a blank sheet or not. So anyway, but let me give you the method as quick as I can, because I think it's important to see, especially if you're thinking of doing something like this, to see how did we make this sausage? Okay, first of all, one of the givens was don't start over. from nothing. There were already several good articles in the literature, and these are the ones we drew from. And actually a couple of others have come to light later that we could have drawn from, but these were important articles. And so the first thing we did is to synthesize them. And I did that. I read them all, and I put, if you take all these together and you said, what are they as general competencies? What are they? What does it add up to? And the amazing thing was it wasn't that hard to do. Even though there was one for psychologists, one over here, when you took the covers off, they were getting at very similar things. And so it was possible to create one list from them that embodied them all. And one of the things in the method that we did is to, at the end of the statement of here's what we think these 4 articles boil down to in terms of these 7 competencies, ending up being 8 later, but 7, we gave examples drawn from the articles of what you would see in action. Like what observable thing, what would a therapist you'd see doing in the clinic? All those articles had a lot of those examples. We pulled them all out and organized them together under that competency, even though in the original articles, those examples were spread all over the place because they didn't organize it that way. But this was part of the strategy for the mom and apple pie all the way to the concrete and granular. We would put a name for the competency and a little description, and then bullet points, and then 2 pages of examples of what it would look like on the ground. So people that want to see, I want to read what it looks like on the ground first, could do that. Others people say, don't give me all those details first. What is the thing first? You know, everybody could have a way of being happy with that. So then we created this version, but we didn't want to have an all-day meeting with that alone. So we created an online survey. And the question for everybody that was coming, 80 people that were selected from around Colorado, the foundations, the provider groups, behavioral health and medical, some psychiatrists, foundation people, government, state people, the SIM grant people in the governor's office, 80 people. Is this competency good enough to use in Colorado? 3 things to check. One is, yes, it's just fine as written. So, bing, if it was a home run, great. Yes, but it needs to be sharpened up first. And then there's a place for them to type it in. What would you need to do to sharpen this? And then there was one that says, no, this is not salvageable at all. And why not? What different would you need to do? So then all these 80 surveys came back to me, actually. And it turned out that most of them were either pretty close. A few were just fine as written, but most of them were pretty good but need to sharpen up. And there were like 10 pages of comments for each for how to sharpen them up. And they were very, amazing thing is there were many things that were similar. So then what I did is, number 3 is to rewrite it and distribute it for the use at the all-day conference. And I made all the obvious non-controversial improvements. Oh, duh. That's so much clearer. Why didn't I think of that? Most of their suggestions were non-controversial, obvious, and you could just do them. So I just fixed everything that was like that. But there was a small number of things that were controversial and that needed consensus and discussion. Those became the agenda for the all-day meeting. Because when you put people together for all day, they can't go over trivial stuff, and you can't just give them the whole thing to work on. So that each table had, here's the controversial thing you have to work out. Table 1, 2, 3, 4, 5, 6, 7, 8. And that was the agenda for it. So the tough areas had to have face-to-face resolution. And we used the face-to-face time all day long to crack the emerging specific tough issues for what are the competency really here. What is this really that we need to say? And there was 2 rounds. One was the first round of people took the tough areas, 1 per table. Then they reported out, and people said, we asked, okay, how good is this? The good majority agree. Anybody can't live with it? And then the person that can't live with it, you get to give the speech a why? Then I said, oh yeah, we could fix that just by doing this, couldn't we? So, is this okay? And then everybody go, yes, no, that kind of thing. So we would fix those things, but there were still some things left for a second round that weren't resolved the first time. So we recalibrated what those were, gave them to other groups for round 2 to finish the job. And then that's how we got the thing, and then did an individual feedback form. If we have time, I'll show you the results of that, to assess their confidence in the day's work. And then after that conference, I rewrote it again and of course when I say I sort of was like the chief editor, but it went all through our group, Sandy, Ben Miller, Larry Green, the others, Emma Gilchrist from our planning group. So I mean, I was sort of like just an editor. I mean, it was a group effort. And so then I rewrote it based on this work. And here I got to say something else. When I made an edit, even at the very beginning, when I said, here's our initial take, and here are all the non-controversial changes I made, I put them all in highlight, so they could see exactly what I changed. Instead of it's like, well, look, I can't remember what it said before, but I don't know. What did he change? Well, it was all in yellow. Everything I did different. So every time I changed their description, see, this was not my product. This was their competency statement. And if I mess with it, they have to know what I did. So those changes were edited. It showed. Then when I, after the conference, did the same thing, showed all the edits so they could see what I did. And I invited them in the email, said, you know, if I did violence to what you meant, you got to say so, but here's my best take at what this was. And then we tested it again with the online survey after the conference. And is it okay as written? You want to sharpen it? And there was virtually no non-salvageable things. And then we wrote the final report, but again, there were a few things to fix that I could easily fix without having to go back. It's like, well, thank you for the improvement. But it doesn't need another meeting to find out if you agree. Okay, so you get the idea of the method there. There's a lot of detail, but the idea was they own it. I am helping them discover their truth together in a transparent way, and not waste time at the meeting by coming together and say, hey, blank sheet, what are the competencies? I mean, where would that have gone? It would have been just another one of those competency papers, you know, that with uncertain status in the field. Okay, so then, we did, right after the meeting, or after the rewrite, after the last rewrite, or right the second to the last, we asked people those questions about whether it's you know, good enough as it is and so forth. And by this time it was down to 35. The people that came to the meeting in one of the biggest blizzards that Denver had seen for a long time. In fact, one of the groups had to stay in Colorado Springs and do everything on the phone. But they were a group. We're going to be a group, but we're going to just have to be on the phone. And so we had, these are the percentage of people that came, that disciplines and people that were in the mix. And here's what they said at the end, almost at the end, second to the last, was just fine as written, or yes, but needs to be sharpened. You can see that's like almost everyone. And at the last round, the sharpening were minor edits. It was like they're being good editors. There was nothing substantive, things I could just fix. They were even pointing out typos. And there was 1%, 3 people said that there was something in it somewhere that wasn't salvageable, but we figured that if 99% are okay with it, that's a good majority agree, and we didn't ask that person if they could live with it, but so that was the thing about it. So anyway, here was the cover page of the thing, and I brought a few of them if any of you want to take them with you. So there was a preamble. Are you going to do that, or do you want me to? Okay. So one of the things they said is we can have competencies, but you need a preamble to put them in context. So here's what the preamble is. All competencies have a target for a definition, a functional definition of what is integrated behavioral health. Like competencies to do what exactly? So they say use the ARC definition. Well, I'm not repeating it here, but there is one 2-sentence definition, and then that's what these are aimed at. And then there was a lot of stuff that people said on every competency. Well, don't forget prevention. Don't forget across the lifespan. Don't forget generations. Don't forget culturally sensitive. But you didn't want to repeat those for every single thing. So he said, here are the cross-cutting things We're not going to repeat them with every competency. They apply across them all. And then, this was not for any one model. This wasn't for the impact consulting psychiatrist model or PCBH. It's just if you're a behavioral health person in the clinic. And then they had how to read them in the 3 altitudes. So the structure was a name, which is real mom and apple pie. Obvious, like duh, like Sandy said, why would you go to Denver for that? And then a 2-sentence description, which is a little more granular. And then a bullet point list with headings and some details. And then finally, a page or 2 of concrete examples of what you would see in action, what it would look like if you were sitting there looking at people doing things. So it got from mom and apple pie to granular to satisfy the lumpers and the splitters. And they were expected to evolve over time as you field matures, like Sandy said at the outset. So we don't have time to go through them all. We're not going to, but we picked, here's the mom and apple pie list. By the way, I have a few copies of these, most of these slides, at least something that's close to what these slides are. People want them here. But we picked out some in red that we want to actually delve into a little bit because there's certain things that aren't so obvious in them.
We're also going to give the slides to CFHA to go on the website.
Yeah, right. So this whole thing will be up there. So do you want to do that one? These things here, these at least a couple of these.
Okay. We want to unpack it a little bit. To work as a primary care team member to create and implement care plans that address behavioral health factors. It's interesting, this one came out as one of the 8, and it was, I think it's partly because this is a competency that gets more complex as you go into it. The patient-centered care plan, a care plan in which the patient is involved and all of the providers are involved, is an amazing and powerful tool. And much of the future of the transformation of healthcare, and if you look at these regs, presumes this kind of work. Work that's, people, as far as I can see, who are making up the regs, are kind of just saying, oh, well, we'll just do that. And just doing that is a real challenge. So you have to be able to include and involve all of the various kinds of elements that a person is getting care about. You have to help the team negotiate care plans. I've done this, and it involves several days. It is not a one-sitting thing. It is something that changed when we did it well. It changed the relationship of the patient to the care team substantially. We often did it in situations where the PCP and the patient were polarized, and doing a patient-centered care plan would often really resolve that polarization. It causes the team to have to think differently about the patient because of the patient's input on this care plan. It is an issue that is going to hopefully, I mean, if you're going to do it right, then this care plan ought to be popping up on anybody's computer who's going to be working with this patient, not be something buried in the back of the EMR. And that means that the patient, when they go to the next provider, is going to say, did you read my care plan? Do you know it? Because if they're not, we have a problem. This is a core piece of work, and it is a synthesis that transforms the relationship of the patient and the team, and makes things possible that previously weren't possible. And I'm seeing a lot of heads nod because I know people who are clearly have done this kind of work.
I want to point out, see, it says elements listed. Actually, there's a list of 7 or 8 things that need to be in a care plan that the group agreed on. That's not listed here, but it's like to get granular again, because it's easy to say care plan and then what's in it. So let's do it.
Why don't you do it?
Okay, well, so this one now we pulled out too because it was a little different, and there was a lot of conversation about whether the behavioral health providers have any particular role about observing and improving the care team function and relationships. Are you coaches for the team, or are you just there for the patients? And so what came out here was that the behavioral health providers help the primary team monitor and improve care team function and collaborative relationships as part of their job, not just because you're interested in it and volunteer. But again, in Colorado, when you're hired, you be prepared to do this. And so, for example, there was pooling knowledge and so forth they have, and then being flexible in the role and work style, and helping them engage, how to engagingly introduce the behavioral health provider and so forth. There were a number, help the team identify and respond to problems. And there were discussions, how do I bring that up? You say, well, if you normalize this part of your job, then if you say, hey, you know, I've noticed this was awkward for us, wasn't it? Everybody would say, oh yeah, that's part of your job, thank you, rather than who the heck are you? And so that's the value of having this, and then sharing responsibility for achieving the triple aim. We're all in this together. So there's a couple of things that are different on that. And let me go into this one just a little more. This one took a lot of time to figure out because it was originally, it says now, provide efficient and effective care delivery that meets the needs of the population of the primary care setting. The original version of this is learn how to do short visits. And then you could see where that wasn't going to quite work, but it was on to practice management. It was on to something important, but that wasn't the way to do it. So this took 2 rounds in our meeting. And here's where it landed, that the behavioral health providers use their time and effort on behalf of the practice population, setting prioritized and agendas with the patients and team. And then as far as the time goes, it managing brief as well as longer patient encounters effectively and identifying areas for immediate and future follow-up for where you maintain behavioral health availability. That's like, don't be booked up. And so then it said, here are some distinctions that every behavioral health provider has to master. And I'll just give you highlights from it. The difference between a clinic's panel and your caseload. That a behavioral health provider's time in primary care is focused on serving the entire clinic panel, although they may be in their clinic be focused on a particular chosen subpopulation, you know, like kids with special needs or something. The clinic can decide what's the population for this. But whatever that is, you're just on that. You're not there just until your caseload gets filled up. Okay? And then the other one is, what is efficient and effective? There's no such thing as efficient care that's ineffective. And therefore, efficient doesn't merely mean fast or short. Efficient and effective means care is clinically effective at the same time it is done with a minimum of wasted motion, rework, delay, or cumbersome method. It's like the word concise, the minimum words to get all the information across. And so that was one. Another one was brief and long visits. The right appointment time depends on what the patient's needs at that time and might range from a 5-minute intro or warm handoff to a 15 or 30-minute return visit to a 60-minute or longer evaluation visit. This competency involves flexibility to consciously match visit time to patient need, not to assume default or habitual 50 minutes or 15 minutes or whatever minutes. Okay. So those were, and then brief versus longitudinal. Like primary care is like cradle to grave. Well, you might be seeing people cradle to grave too. It's like brief can be longitudinal in that, you know, 5 years later they might need a little of you too. Not just you're done after 3 sessions for your life. So those were examples of things in Competency 6. Do you want to?
Do Competency 8?
Sure.
Okay. This was the one that got added, right?
Yeah.
8, yeah. So as the process went on, we decided that it wasn't just that you would learn to work with everybody. That didn't seem to be quite enough. And the group wanted to say that you would learn and be, if not fluent in, at least able to get around in the language and values of other disciplines, and that you would value those disciplines and be able to understand and work with not just the people who came from them, but the contribution and the roles that those disciplines can help. So that, and that the differences of disciplines is an inherent piece of this work, that it is not like, gee, those such and suches are all so sensitive about this, we hope they get over it. Even though I hope they do. It's that people are raised in certain ethical and values environments, and so of course they carry those with them. And we can figure this out, but our role is to be recognizing and comfortable with, and maybe even facilitative about the valuing of these various cultures that we call disciplines.
Yeah, that's good. Okay, so that's a snapshot of these. There's more in it, but you get the idea. And many of these were hard won in the groups, across the disciplines, going against each other, the settings, the different kind of people involved were doing that. But in the end, they were happy with the way the things came out. So a little bit, what's happened to it? So this is information from Colorado. Originally, Ben Miller was going to join us and actually tell us the fun stories in his own inimitable style, but he was unable to stay this long. So this was presented, it took a place in the Colorado SIM grant, which is, I don't know how many $1 million, it's about 400 practices that are mainstreaming. Gazillion practices across the state. A gazillion dollars. Yeah. And many, many millions. And so there are collaborative learning sessions, and this became anchored. This is a way for all of you to think about what your behavioral health providers do, how to hire them, the training organizations in the state. Here is what we need to train for. We can compete the heck on our curriculum and being good at it, but this is what it has to be shooting at, okay, across these things. An e-learning model for practice teams is being developed that does get more into the team aspect of it. NCQA, we've talked to them about how these might be able to be incorporated or aligned with the PCMH competencies for behavioral health that are in the NCQA standards. That's a conversation that's in process. The number of organizations have picked it up as a resource document, Hospital Association, and so forth. There's 3 articles have come out this year that use it. And the scaling up and adoption, the Farley Center is working with the Colorado Health Foundation, the Walton Fund, Family Foundation on strategies to scale it up, to get it really involved. And I don't know if you had, I can also say a little more. No? Did you have anything from the little message from Ben that you want to add?
In fact, what he did was to go through that information. He sent us a little video, and it had a pretty film of boats, and behind it, he voiced over. But it was basically
pretty I said, but we couldn't get it to open here, so we missed the boat.
We missed the boat.
So I guess the bottom line is that it's in process, it's being applied, but when you have a whole state and all these practices and health plans and teaching institutions, some of our schools, some are inside of provider organizations, adoption is this process of absorption and work, and this has only been out less than a year. That's only been out about 9 months. So that's progress so far. Actually, there is something that Sandy should talk about, because he's got his own application.
So I have been teaching the primary care behavioral health course at UMass, the online course, for about 10 years. And this last spring, I also began teaching a graduate course in primary care behavioral health, which was similar. And I wanted to see how the evaluations of the two courses might or might not correspond. So I used the same evaluative tool for both of them. And the tool is longer than this, but at the beginning, I put on the 8 competencies to see what would we get. Would people be able to distinguish something about it? It's worth saying a little bit about this method in general, which is the retrospective pre-post approach. The retrospective pre-post is, I'm going to ask you after you take the course, how much did you know about this particular element before the course, and now how much would you say you know about this element? It is better than actual pre-post in evaluating coursework, because before the course, people don't know what they don't know. And so they tend to give themselves very good grades. Then they take the course and they go, oh hell, there's more to this than I thought. And then they give themselves a bad grade because the course was effective. And so the retrospective pre-post is more effective. I found some studies. I have to say there's not much literature on this, but there were a couple of studies where they did retrospective pre-post evaluations of medical students learning a behavioral health kind of skill, and they also observed their practice in that skill, pre and post. And what they found was that while any one person is not reliable at telling how their skill has changed, as a group they were. And so the group scores for the self-perception pre-post correlated well with the observer scores of the change of practice behavior, which is enough for me. Thank you very much. Now we're going to go. So I'm just acting like this is a good thing to do. So what you see here is the pre is the red, and the green is the post, and on each question, how well, it's a self-perception, how well do you identify and assess behavioral health needs as part of a primary care team. So it's a self-perception about your skill. And the numbers is the percentage of the audience who gave each number. 1 is not at all, and 7 is totally got it. I'm not sure what the words were, but essentially, I can do this stuff. And what you see is that it doesn't tend to change the variability in the audience that much, but the whole lump, the whole variance moves over. And so and tends to consolidate a little bit in general. And so I was very happy with this, both as feedback. This is on the folks who took the course at the graduate course. It is not everybody who took the whole other course, because they have not yet given me that data. But from the graduate course, this is it, and I'm liking it as a sort of a summary tool. And then we're going to, because we ask questions about sort of much more granular skills down there, we're going to be trying to compare the granular skills and the summaries here, and then across from the graduate course to the online course. But there it is in used once in course evaluations.
So that was there's an example of an evaluation. So we're really talking about now moving into the discussion, and I don't know what happened to my slideshow here, kind of, but the question about it moving ahead together, and a lot of you said you need common competencies, you know how to move ahead together rather than rolling your own, which was a good joke in Colorado at the time. That had just been legalized. Yeah. And so you probably need to reduce cacophony where you live, and you need to probably find out who cares about cacophony and so forth. So adopting a basic approach together, we're going to talk about that. And you probably don't want to start with a blank sheet. And so how can you go? So here's some discussion questions for you, and we'll open it up. So how would you, and you don't have to answer these, but this is to get you thinking, how would you know that working with a concept of competency would be useful where you are? And are any parts of this that would be resisted or have no traction at all where you are? And does your situation require consensus? And with whom? And so just to get your thinking about that, why don't we open this up? Yeah. And ask your questions, make your comments, and we'll do as best we can with our remaining 10 minutes or so. Yeah.
I think one thing that I think about with this is we have multiple clinics, and in some cases now we're gaining enough staff to be able to cover when a behavioral health consultant is gone from their respective clinic. So when you cover, you need to be able to step into that role in a way that's very similar to what they're doing on a daily basis. So consistency in really making sure, even though I may not be there every day, that when that's gone, a patient isn't going to feel like they're getting a different service. It's really important.
Yeah, that's a great comment too. That's part of it.
On number one, a couple years ago we went through mental family therapy training certificate program at one of the universities as providers. We were given things afterwards as tools. One of those was a list of competencies, and we did a self-thing, check out yourself, see what you think you can do. But what I did was take those medical providers who haven't vetted or wasn't vetted for medical and ask them to look through those and to tell me what would be more useful to them for me to work. So that, and they were all happy to do that, and I got some incredible feedback, and it helped align, what they needed in line with what we were able to provide. And so that was very useful.
That's fantastic.
Mhm.
And do you have a list of what they kind of tended toward?
I do, about 4 or 5 pages. I don't have a list here, so about 4 or 5 pages of different competencies. So, and a lot of it was, just off the top of my head, some things I can remember, a lot of it was increasing knowledge, like psychopharmacology, different things like that. So, yeah, it was a really useful tool. So,
I see this as a thing that a group could sit around and chew on for a long time, and that it would be, I'm guessing, bonding to the group, and the idea that the customers would be there too, not just the behavioral health people, and that you could take a competency a week or a month and just chew it together and see how it related to your setting, and I think you would end up with a sub-report for your setting that would be, it would be a specification of the mission, possibly. I mean, it really could be a very meaningful piece of work. So yeah.
What do you have input from everybody across the state? Were they from all different types of integration models, vertical and horizontal ones?
Were they from different kinds of integration models? Yes.
Yes, they were.
They were.
There were consulting psychiatrists there using the impact level type of model, collaborative care model. There were PCBH folks there. There were social workers had their own sort of variation on that. And what we tried to do is say that we're neutral as to operating model. Whatever operating model you want, but here's what the people, no matter what model they're in, need to be able to do. Because these are neutral with respect to model. Actually, that was one of the givens we didn't mention.
Yeah.
is that this isn't going to be so closely tied to one operating model that people say, well, I don't do that.
Yeah. And there was a bit of discomfort at first particularly among mental health people who were new to the process or who were frustrated in their setting, saying, well, aren't you going to shape up the doctors? How come it's all us? But after a while, we just kept coming back, no, we're not saying anything about the doctors. We're saying about what this one role could do, and it gives us a foundation to move to a possibility of conversation with the medical clinicians in other roles in the process.
As I've been thinking about this and thinking about where people are operationalizing these various competencies, the thought is about, how can you articulate each one in such a way that, let's say, of a grad student, medical preceptor, it goes through their lens, and then also provides a way to engage the other members of the team to get their perceptions of also what that PhD is doing.
Yep.
So now all of a sudden in a single rating, you've got a student who is doing something, preceptor that's observing, and engaging with the other team members to get this multiple rating.
Yeah, I agree.
Actually, that's one of the things that, here's, for example, every one of these has examples of what you would see on the ground. These are highly concrete things, which again is the lowest common denominator that if you're preceptor, what am I seeing? So you can go to the granular. Part of the dilemma with competencies is they have to have names and titles and brief descriptions, because if you give them a 100-page document, oh, it's overwhelming. But then the minute you give it to them, you say, what does this mean? So you have to do it both ways. It has to transcend altitudes. It has to satisfy lumping squares. But I think in that question, when you go to the details, is this what we all want to be seeing?
Mm-hmm.
Now let's back out of that into what is the abstraction of that?
Yeah.
And then in the end, what shorthand might we use to express it? That's the name of it.
And if you see it, how do you scale it?
Yeah. Yeah.
Right.
And yes, and the idea of that we would be able to describe it so much with the term in the biz is behavioral anchors, that we would have behavioral anchors that were so specific that when you saw it, you can say, do that, that's always the right thing to do, and then except when it's not. And so if at the point that you're going to do an interaction that's really fully competent, that's a lot of videotape to watch, because there's no one piece of it that you're going to be able to identify as competent. And so it seemed like we would end up with being able to foster a conversation or create a foundation that people could build off. And if somebody wanted to build the behavioral anchors for their world, whatever that was, and do it, well, that would be fine. That would be great. But we didn't feel like that was what we wanted to do.
Not only that, but this is where the family of applications could come in. If you guys are interested in building a field, that is all around the country, across disciplines, people would recognize a core subject matter. Like in physics, people recognize a core subject matter. It isn't just North Central U.S. physics and Southern California physics or astronomer physics. I mean, it's physics. And so how could we build this so it's a coherent field by having a family of locally appropriate variations on something that's recognizable as having a common pattern and building a field? That would be the part of the challenge. They're doing it in Colorado, but the challenge nationally is let's build a field. Maybe you could use something like this.
Yes.
So you pointed out that your charge was specifically to do this with behavioral health clinicians. Was there a parallel process going on to define this is the dance moves for the behavioral clinicians. Was there defining the competencies for the medical clinicians so that they could be ready to dance appropriately as well?
That was going to be another day if people wanted to do it, if there was foundation and clinician interest. But that was more than we could take on. Yes.
You say what the PhD is doing.
Yeah.
What are patients actually experiencing?
Yes, that's right, that's right. And that piece of what is the patient's participation in all this and experience is an obvious next step, absolutely.
But again, it's one of the things, the insight is, we have all these, it should be the whole picture. But then, if you really say, let's do the whole picture, what do people feel like in the room? So you have to have a place to start, that you build, you design the starting point, to have an architecture that can be expanded indefinitely. And you keep the people with you so you don't start losing people. Where they say, well, they never listen.
This is open source stuff, folks.
Yeah, it was open source, but also the people didn't say, well, they didn't listen to me here, I didn't really agree with it here, we didn't agree with it, because we monitored this consensus process that closely, that we didn't lose the crowd in the process.
Last question.
So,
Yes, Rob?
to the extent that this was designed to be helping Colorado roll things out, is there a plan to do a check back at 18, 24, 36 months about what else needs to be, where did we get it right and where do we need to revise it?
That doesn't answer that.
No.
You answered that.
The answer is I don't know.
Yeah.
That we stand ready if they want to have us come around again. I think there might be energy, but things, move on. So I don't know.
We don't know. Yes, but we stand as, Sandy was the outside, out-of-town curricular training expert, and I was the process designer. They're going to follow my rules in the process. And actually, you might say, we asked them at the end a lot of questions. So how confident are you? What extent are the proposed next steps clear and practical? What extent was it well-designed and not? Notice where the dots landed on that. When you get people in a big all-day consensus thing and a really fuzzy topic, and you get that distribution, it's not that. So, thank you very much.